So next case is splenic trauma. It's V41. A 23-year-old woman fell off a horse, landing on her left side. Chest X-ray shows left rib fractures 10 to 12. She is tachycardic but not hypotensive. How would you treat her? So I would assess and manage the patient with ATLS principles: airway, breathing, circulation with C-spine control, oxygen and analgesia, 2 large heavy bowl cannula, 1 liter fluid, bloods, group and safe, cross match, clotting study, pregnancy test, chest X-ray, pelvic X-ray. If she has no loss of consciousness and her C-spine examination is not painful, we can declare it's clear and take a history, ample, perform secondary survey head to toe, including additional imaging and perianal sensation. A fast scan can be done. It's quick and reliable to see any fluid in the left side, risk fracturing the ribs on the left and injury to the underlying spleen. Then we will proceed to the CT with contrast to rule out any other intra-abdominal injuries and spinal fracture. What are the symptoms and signs of splenic injury? So abdominal pain, peritonism, Caher sign, left shoulder pain, and associated features will be left rib, low left rib fracture, bruising of lateral chest and abdominal wall. How do you grade splenic trauma? So grade 1, less than 10% hematoma or less than 1 centimeter laceration. Grade 2, 1 to 3 centimeter laceration and 10 to 50% hematoma. Subcapsular. Grade 3, more than 3 centimeter laceration and more than 50% hematoma. Grade 4, 25% of the spleen is devascularized due to the hilar vessel or segmental laceration. And grade 5, reward to shatter spleen or hilar injury that devascularizes the whole spleen. And this patient has a grade 3 injury and is hemodynamically stable. How would you treat her? So she needs conservative treatment. This is a blunt injury, hemodynamically stable. So splenic embolization can be considered to prevent later pseudoaneurysm formation, later bleeding. She needs serial abdominal exams, full blood count, advised bed rest, no vigorous activity for 3 days. And there should be a low threshold for splenectomy if she becomes unstable. If initial management is successful, obtain a follow-up ultrasound scan at 5 days to document non-progression of splenic injury. Next question. Her blood pressure drops to 70 or 30 in the ward. Abdomen becomes distended and her blood pressure does not respond despite resuscitation. What do you do? So arrange for emergency laparotomy, consent for splenectomy and post-splenectomy vaccinations. At laparotomy, I would pack all the 4 quadrants, suck out all the blood, confirm the source of bleeding, control the bleeding of the splenic hilum by finger pressure while anesthetists catch up with the transfusion. If the patient stabilizes, I would consider spleen conserving measures. Topical agents, fibrin glue, metasplagate sutures, vital mesh wrap, and organ beam coagulation. If patients remain unstable, I would remove the spleen. So first I will divide the lienorenal ligament, bring the spleen into the wound, compress the vascular pedicle between finger and the thumb, enter the lethal sac, place the splenic artery and palpate the splenic artery and ligate it, separate the left colic fracture from the spleen, divide the gastrosplenic ligament and short gastric vessels, double tie and divide the splenic pedicle while avoiding the tail of the pancreas. Place a drain in the splenic bed. Keep the NG tube post-op as post-operative acute gastric dilatation may occur. How might your management of splenic injury be different if the patient was 12 years old? So in pediatric age group, the success in the conservative management of splenic is good, better. However, in children, in the presence of contrast, blush at CT scan is not an absolute indication of splenectomy or embolization. Ultrasound follow-up is advisable to minimize the risk of life-threatening hemorrhage and associated complications in children. The risk of pseudoaneurysm of splenic trauma is low. For children, normal activity is considered safe for 6 weeks. For adults, it's 2 to 6 months, no contact sports. The patient becomes febrile on the ward on day 3. What are the possible causes? So infective causes and pneumonia, atelectasis, UTI, wound infection. And specifically known after splenectomy is line infection, intra-abdominal abscess, in trauma context, missed hollow viscous injury, acute gastric dilatation, most common blastectomy. What changes are seen on the blood film after splenectomy? Whole jewelry bodies, pepin granules, plus thrombocytosis, and left shift in the differential count. What is OPSI? It's overwhelming post-splenectomy infection. It's flu-like symptoms followed by malaise, headache, coma, adrenal hemorrhage, and circulatory collapse. It affects 2% of the trauma splenectomies. It occurs in the first 2 years of operation, and Mortality rate is high, 50 to 90%. It is due to encapsulated bacteria, H. influenza, Streptococcus pneumoniae, Pneumococcus, Meningococcus, and H. influenza. What is the post-operative treatment after emergency splenectomy? Patient should receive immunization 2 weeks after the operation, including Pneumococcus, Streptococcus, Pneumococcus, Meningococcus, and H. influenza. And for patient immunization, patient should get seasonal flu vaccination every patient over 6 months of age every year, and malaria prophylaxis if they are going into the malaria pandemic areas. Antibiotic therapy should be strongly considered in the event of any unexplained fever, malaise, or chills. Primary GP should be informed, and patient should be holding all the time medic alert bracelet or splenectomy patient card in the wallet. Guideline on the antibiotic prophylaxis is very at risk of OPSI goes down over time. Some guidelines suggest that the first 6 months of the treatment and first 2 years. High risk patient should benefit from lifetime prophylaxis of antibiotics, and young patient may benefit from longer duration of prophylaxis until adulthood. How does the splenic electrosplenectomy differ from the emergency splenectomy? So indications of splenectomy are hematological disorders like hereditary spherocytosis, ITP, autoimmune hemolytic anemia, or suspicion of specific malignancy in the splenic malignancy. Vaccination should be performed pre-op 2 weeks for meningococcus, pneumococcus, and H. influenza. It can be performed laparoscopically or open. The steps are entry into the lesser sac, division of the splenocolic ligament, splenorenal, gastrosplenic ligament. Some surgeons prefer to leave the splenophrenic ligament and intact until after salvage dissection to prevent the rotation of the spleen. Isolate the splenic artery. Dissection and division of the splenic hilum with a vascular stapler, or by individually clipping the terminal branches entering the hilum. Retrieval in a bag and morcellated to reduce the size of the extension strand wound. This is for laparoscopic splenectomy. How would you approach a patient with a splenic cyst? So again, cystic lesions of the spleen are included in common entities. So cyst surgical intervention determine the cyst size and symptoms. Small asymptomatic cysts with no suspicious radiological features can be left alone and observed. Cysts more than 5 cm or higher risk of rupture and intervention is indicated. Options include percutaneous drainage, alcohol ablation, or splenectomy. If parasitic cyst, percutaneous interventions are contraindicated. Spillage of cyst content must be avoided both pre and intraoperatively to prevent life-threatening anaphylactic reactions. Thank you.